Okay, sorry about that interruption. That was actually the director of our group, just wanting to touch base on some things. And if you're not a fan of Ole Miss, that's fine. Neither am I. I just like the tune Dixie, and the Ole Miss fight song is the best recording of it, so that's why it's my ringtone. Anyways, so back to the insulins, the chart on page 238. You're going to learn these as you practice. Start with the basals. The questions that I'm going to have for these really are going to be more about how the insulins work rather than at what point should they be added. Now, I'll tell you why. Pathophysiology, we'll talk a lot more about diabetes in your clinical courses, and I really need to look and see at the curriculum if there's a course that is truly based on putting pharmacology and pathophysiology together for actual treatments. That's when you're really going to learn how to do this. And let me tell you, there's no formula to it. Some people will say, well, I've got a formula. You do this times this divided by that, subtract this, and whatever, and then you know exactly how much insulin they need. Good luck with that. I'm more of a throwing darts at the Irish pub sort of thing. If it seems like it's working, that's great. I'm not going to change it. If it's not working, I'm going to change it till it does work, okay? Sorry, that's all I got for you. But I have been successful. Okay, so let's talk about pregnancy, gestational diabetes. Okay, so we're always worried about treating pregnant women. What can we treat them with so their children are not born with 3 eyeballs? Well, most anti-diabetics are actually, at the worst, a class C. Most of them are class B. So just make sure you check your reference, but treating women for gestational diabetes is actually pretty doable, so no worries there. Elderly people. This will probably be a quiz question because this is near and dear to my heart. My grandparents are both in their 90s. I may have spoken about them on previous lectures, but they're the coolest people in the world, and I'm very close to them. And they have lived a very long time, and if I've learned anything that I should have learned in the hospital and treating patients, I've learned it from my own grandparents, is at a certain age, there's a lot of crap we really don't need to be treating. And my grandfather is diabetic, and I'm actually not sure that he's even really diabetic. I think it was a trash can diagnosis from 40 years ago, and no one's ever bothered to investigate it. But the moral of the story is he's been on all these anti-diabetic medications, which have done nothing but harm to him. Constant hypoglycemia, worsening renal impairment. Well, guess what? I took him off of all of his anti-diabetic medications about a year ago. He's never had hypoglycemia. His glucose has never been greater than 140, 150, and his kidneys got better. So, do what you want with that. But when it comes to elderly and diabetic treatments, be very careful. Hypoglycemia is a bad thing, all right? They'll fall, they'll die. It's just not good. Okay. Oops. Well, it looks like chapter 14 is not the endocrine because it says neurological in my book. So let me cut this video here. As far as the diabetes section goes, I want you to understand how these medications work and probably mainly what their side effects are. Do know that it's okay to mix and match these things. All right, there's not check the American Diabetic or Diabetes Association website. They've always got their most updated recommendations, and it's if you ask an endocrinologist, I mean they've got their own Hogwarts wizard calculation for how they do it, and each one of them is different. Okay, so know how the medicines work, side effects, and you'll be good for this quiz. Okay. All right, we'll be back with other endocrine diseases.